Okay, I think we will go ahead and get started since for those of you who are on time, I appreciate that. As I mentioned, some housekeeping items. If you could please mute and yourself and hide your video, and then we will put the questions in the chat. For those of you who don't know me, my name is Karen Weeks, and I'll be your moderator today. And it's my pleasure to introduce Gaby Bernal Loroi. Gaby is the CEO for Santa Rosa Community Health, which has 8 clinics which serve more than 42,000 people, 75% of whom identify as racial or ethnic minorities. Gaby uses her bilingual and bicultural Mexican heritage to center equity for SRCH patients, respond to community needs, and nurture almost 6,000 diverse staff. She started at Santa Rosa Community Health in 2009 as site director for the largest clinic that serves 24,000 plus patients. In 2018, she was promoted to Chief Operating Officer and was selected as Chief Executive Officer in 2022. Gaby holds a Master's of Social Work from San Francisco State. And with that, I'd like to introduce Gaby Loroi.
Thank you so much, Karen. Good afternoon, everybody. Thank you so much for having me today. I'm pleased to be presenting to the League of Women Voters. What I have prepared for you today are some slides that talk a little bit about our organization and where we fit into the healthcare landscape, and how these potential cuts are going to affect us. And then I'm also going to talk a little bit about give you just kind of a summary of all the different changes that are happening based on the changing federal healthcare policy. All right, so let's get this going. All right, is that right?
Yes, it is.
Okay, wonderful. All right. So let me, all right. So Santa Rosa Community Health is a federally qualified health center. And this is a community health center network that was actually established in the 60s during the War on Poverty, when a group of individuals saw that there was a, a lack of high quality, accessible primary care health services in various communities, usually communities that had people that were low income, that more immigrant communities, people that already had a lot of barriers facing them, also did not have good access to medical care. And so this group started on this mission, this movement to build high quality, equitable healthcare with a community voice. And by that, I'm happy to share that 51% of our board of directors is comprised of health center patients, and that is by federal statute. So our health centers and all of the services that we provide are designed with the patient voice, very prominent patient voice, and I feel that is very unique across the healthcare landscape. So community health centers across the nation serve about 34 million people. As you can see, we take care of a lot of people of color, a lot of people that have low incomes, so a lot of Medi-Cal people, a lot of people that receive other public insurance, Medicare, Medicaid are our two big payers. And a lot of people that are uninsured throughout the nation. 18% uninsured is actually kind of high. In California, we have achieved a much lower uninsured rate, and that is because California has participated in Medi-Cal expansion. So since this became effective in California, no one in California, regardless of immigration status, there's still income guidelines that you have to meet. But regardless of where you come from, as long as you meet the income guidelines, you are eligible for Medicaid. And this is one of the things that is changing in the state. And the reason this is changing in the state is because of the federal changes. because the federal changes then drive the state changes. But again, throughout the nation, community health centers have been a really critical uh, provider of healthcare in all communities. 1 in 10 people in the United States get their health care at a community health center. And again, this just points to how good we are at taking care of various populations of people and how many people just access community health center services in general. So we serve a lot of people that are experiencing homelessness, lots of kids. At Santa Rosa Community Health, we actually just opened our 9 location, which is a pediatric expansion clinic in Southwest Santa Rosa, because there was high demand there and we could not meet the demand of the community. So we just opened another clinic to be able to get closer to providing enough access for all the children in Santa Rosa that need care. We take care of a lot of veterans throughout this network and more patients over 65. And right now at Santa Rosa Community Health, we are actually preparing to take care of more people that have Medi-Cal and Medicare, which is a group that we have traditionally taken care of, but we're going to do it in a much more robust, coordinated way so that our seniors have access to a lot of the services that they need that surround their doctor. So like pharmacy, nursing case management, help with specialty care, and accessing specialty services, those kinds of things. So we are the largest of 6 federally qualified health centers serving Sonoma County. And together with our sister clinics, we take care of thousands and thousands of patients, both in Sonoma County and throughout the state. In Sonoma County, the FQs are Alexander Valley in the north. Then we have Alliance in the Healdsburg area, West County Health Centers on the west coast. And then we are in Santa Rosa. Petaluma Health is in Petaluma, and Sonoma Valley Community Health Center serves Sonoma Valley. As I mentioned, we have many campuses throughout the city that takes care of our patients. And we employ about 600 employees. So this talks a little bit about our local impact. So last year we cared for over 42,000 people, and we are on track to take care of a little bit, slightly more actually this year. We take care of tons of kids, people that are uninsured. 50% of our patients are best served in a language other than English, and we do take care of a good amount of Spanish speakers. And this is one of the things that we've been trying to do in this kind of chaotic environment is make sure that all of our patients who are Spanish speakers and have a lot of fears around deportation and the deployment of ICE agents throughout the country know that they can still come to us and get care. We are telling our patients that if they're afraid to come in at any time, we can easily transition any in-person medical visit to a telehealth visit. And we're coming up with other creative strategies to get care to the people if our patients are afraid to access services. However, I was expecting to see much more of a dip to demand than we have since this current administration took over, but the demand is still very high. So we continue to hire more clinicians, more dentists, more doctors, more nurse practitioners to keep up with the demand for care. So just wanted to highlight the impact of one health center and think about how this impact can be amplified, right, to every health center in the United States that is a community health center. We have really positive outcomes. And the reason that the federal government has so heavily invested in community health centers is because we save them money. Right? So all of the preventative care that we do for all of our patients, which we focus a lot on prevention, leads to lower costs for the overall healthcare delivery system, fewer patients in the exam room, and fewer patients with uncontrolled chronic disease. And it's also good for public health, right? If we make sure that all of our children are up to date with immunizations, that everybody gets their COVID shot, that everybody gets their TB screening, all of that benefits our communities, mine and yours. So at Santa Rosa Community Health, last year we provided care 246,000 visits, the number of visits that we served our patients. We've also done a really good job with making sure that patients that have diabetes, that have hypertension, that have HIV are very well informed about their illness and that we're taking all the right steps to help them manage it. We also are focused on prevention. You'll see that almost 74% of our patients have been screened with cervical cancer. So we do a lot of work there. We also do a lot of work to make sure that our women all have mammograms. And we've come up with very creative solutions to do that. For example, we have a mammography van that comes to our campuses. We don't run it, but we contract. So they come to our campuses so that women can get their mammograms in the same location where they access primary care. And that's one way to bring the care to where we know the women will show up because they trust us, they trust their doctor, and therefore they're more likely to come in for a mammogram. So this is a very, very complex system with a lot of different puzzle pieces that have to come together to ensure that community health centers continue to thrive. There's federal funding, there's state funding, there's federal regulations, there's state regulations. There's also a big 330 grant, they call it, from the feds that helps kind of support our operations. But the point of this is that the healthcare system, how healthcares are funded and regulated, is very complex. We have historically have had strong bipartisan support. Both Republicans and Democrats really have supported community health centers. We receive an enhanced payment rate. So I talked about how we take care of a lot of Medicaid and Medicare patients, and the way that the government ensures that we're able to do that is by paying us more. So a doctor in the community might get paid $130 to take care of a Medicaid patient. We get double or triple that. And that is so that we can take care of uninsured patients and be able to have that cost offset. Currently, our uninsured patient rate is very low, like 8%, because we have worked really hard to make sure that every patient who qualifies for Medi-Cal knows about it and gets access to it. And we have definitely seen through Medi-Cal expansion that patients for the first time are getting their chronic disease managed, or all of these pent-up medical needs that they hadn't gotten taken care of because it would cost them. With the Medi-Cal expansion, we saw a lot more of that. And so some of the changes that we are seeing at the federal level are going to kind of, take us back and erase some of that important work that we have done as people fall off Medi-Cal again. The other thing is that community health centers, our mandate is to take care of everyone. So regardless of who they are, ability to pay. We don't take Kaiser insurance, but anyone who is uninsured or has commercial insurance, we will attempt to contract with commercial services. So we do contract with an array of those. And we have developed a lot of different programs and services to be able to take care of everyone and make sure that everyone sees care here that is specific to them. So for example, we provide gender affirming care services, we provide women's reproductive services, we take care of people that are homeless, we take care of active drug users, we take care of people living with HIV. So a lot of different programs so that all of our special populations needs are met as much as possible. And this is a little bit about how this works. So 63% of our revenue comes from Medicaid, Medicare, private insurance. And then we have a portion of it that comes from other revenue. So this is like some of our 340B pharmacy programs and other kinds of programs. And then our grants is about 12%. So this just gives you a picture of how community health centers are funded. So the impact of all of the changes at the federal level that then cause changes at the state level. So what's going to happen first and foremost is that as Medicaid is slashed at the federal level and they have implemented new work requirements, which means that people are going to have to get in touch with their Medi-Cal worker and re-enroll at a more frequent rate, twice a year as opposed to one. Costs are going to go up for everybody, right? So this means less chronic disease management, less preventative care, less access, period, more emergency room visits, more and longer hospital stays, and higher cost across the board. We're all going to end up bearing the burden of this. Less access for everyone. So that means that there are going to be healthcare providers that are going to have just a lot of demand and it's going to be hard for everyone else. So emergency rooms are going to be slammed. It's likely that some private practices will stop taking Medicare or will close down. And so there's already not enough primary care access, in my opinion, in this county. And I feel like that is about to get worse. The other thing that happens as a result of some of these changes that are confusing and chaotic is that people lose more trust in the healthcare system. And at Santa Rosa Community Health, we've been trying really hard to make sure that our patients trust us and know that they can come to us, not just for healthcare, but for information. We are a trusted source of information. And all of these changes will start to erode that. We have a bunch of strategies in place to stay in touch with our patients, provide them timely information, but it's hard to prevent loss of trust in the whole healthcare delivery system as a result of some of these changes. And then the health of the community will deteriorate, right? We might have more public health emergencies or crises when everybody is funded well to make sure that everyone in the community is healthy. Some of that funding goes away. It's hard for there not to be people that are sicker. So sicker communities, communities that are less educated about chronic disease or disease in general or preventative care. So deterioration of just general health of the community. Okay. So I wanted to show you this slide because it talks a lot about all of the changes that I've mentioned, when exactly they are going to go into effect. And one of the things that I think can be confusing is that people think like, well, all of these changes are going to go into effect at once, right? And that is not true. We have actually seen very slow implementation of some of these changes because there have been significant legal action, a lot of lawsuits around of these things. And so anytime there has been a lawsuit, then some of the changes, the executive orders or the changes in policy do get delayed. However, there's still the bill H1N1 that just got passed, which is going to cause tremendous defunding of Medi-Cal. So just wanted to walk you through this. So in July, Planned Parenthood became a prohibited entity, which what that means is that Planned Parenthood could no longer access Medi-Cal dollars, would not be able to get paid by Medi-Cal. So this change happened at the federal level, and this is in litigation. So this is still being worked out. Skilled nursing facilities there will be an elimination of a quality incentive program and a significant investment in skilled nursing facility workforce. That's happening in December. And then in January, here in California, people with unsatisfactory immigration status will no longer be able to apply for Medi-Cal. So no new enrollees effective January. For people that are undocumented, that are already in Medi-Cal, they can stay on Medi-Cal. However, there will be a monthly fee that they're going to have to pay. I believe it's $30. It was higher, but they reduced it to $30. So it's like a premium you're going to have to pay on a monthly basis to stay enrolled in Medi-Cal. Medi-Cal dental also ends for people that have unsatisfactory immigration status. Loan repayment program ends, and loan repayment programs help put money into communities where there is a lack of enough clinicians. And so it helps put good doctors, or not good doctors, but well-trained doctors and nurse practitioners in communities where there's not enough access. So that is also on the chopping block. The asset test limit begins. This means that they will again be incorporating your assets into the qualification for Medicaid. And they will no longer be covering Ozempic and those type of, Medi-Cal would no longer be covering Ozempic and those types of weight loss drugs. So all of those changes will be effective in January. And then in July, there's a couple of other changes that are happening. So for example, in July, the way that community health centers get paid to take care of people that have unsatisfactory immigration status will also end. So instead of paying us our Medi-Cal rate, our enhanced Medi-Cal rate that I showed you earlier in one of the slides, they're going to be paying us fee for service, which will probably be, I don't know, 10, 15% of what we used to get paid. So that's going to be a decrease in revenue for us. Then in January 2027, work requirements begin. And so this is where people on Medi-Cal will have to more frequently come in and provide their Medi-Cal worker with all of the documentation to ensure that they stay on Medicaid. And what they are counting on is that people will not recertify in time and will fall off Medi-Cal. And so there will be less people to pay for. Let's see. The premiums, the UIS premiums, that's what I talked about earlier, where people that are undocumented will be able to stay on Medi-Cal, but will have to pay a monthly fee. And then there's a lot of changes to state taxes. And the way that it works is that the federal government provides Medi-Cal dollars to every state based on a formula. And then the states have the ability to raise more funds through taxes and other initiatives. And so there's going to be a reduction in that. What's happening is that the federal government is reducing the match for states. So the states are going to have less Medicaid dollars and more restrictions on how they can access or raise those dollars to offset the reduction to the federal match. So anyway, all of this together means less Medicaid beneficiaries and more uninsured people across the nation in every state. There's no state that will not be impacted. And then the midterm elections are happening right around there, right? In October. So we'll see how the midterm elections affect any of this. And then lastly, this just really summarizes for you what I've talked about. So HR 1 was that bill that was just passed in the Senate and Congress. And this budget, in this budget, you'll see the impacts, which are pretty significant. First of all, 3.4 million people across California may lose coverage, both through work requirements, the eligibility check, or just not being documented. So, right, no new enrollees to Medicaid that are not residents or citizens. And then work requirements will become a requirement as far as the eligibility checks. The work requirements, I just want you to know that a very high percentage of people that receive Medicaid already work. So there are people who receive Medicaid that just are ineligible to work because they just physically cannot. And so they'll be okay, but all of these other people that are able-bodied will have to then demonstrate that they are looking for a job, they are training for a job, or they are volunteering. So all of this is meant to reduce the number of people on Medicaid and save the country money. However, if you don't invest in prevention and if people having insurance, then it's actually more expensive when you have to pay for hospital stays, emergency room stays, ambulance transportation, those kinds of things. About 30% of Medi-Cal members in our region, which is Northern California, will be impacted, and about $30 billion in federal funding may be cut. So all of this is going to create a disruption to the Medi-Cal safety net, and including FQHCs like Santa Rosa Community Health, who are the safety net. So those are all the slides that I have. These are just pictures of our wonderful staff taking care of our patients. We were one of the first organizations in the county to provide COVID testing. So you'll see our doctors all geared up there. We also were very active in the COVID response. We opened 2 mass vac sites and vaccinated tons and tons of community members, not just our patients. We had no wrong door policy when it came to COVID vaccine. Whenever you wanted to come in and whatever type of vaccine you wanted, we made that available. So we have had a very prominent role in the Sonoma County healthcare landscape, and are very proud to do so, and will continue to do so as long as we are funded. So just wanted to share a little bit about what you can do. Stay informed, right? It's really important that we all have accurate information to share with our communities. And I will get in touch with the League of Women Voters because we are putting together a bunch of information in collaboration with all the community health centers. And that's going to be disseminated out to the community and community-based organizations because we felt like it was really important to be informing our community with one voice, with facts in easy to understand format for people that have low literacy and multiple languages. So we are right now creating a bunch of different documents, and I'll make sure that you receive all of that because that's really important. There's a lot of misinformation out there. These things are all very complicated, and so we're trying to distill them down to the important information that you need to know so that you can tell your neighbor and your friends about. Stay in touch with your elected officials. This is really important. They need to continue hearing from us that all of these changes are going to have a very negative impact on our communities. Donate to your favorite nonprofit. All of the CBOs, the food bank, everybody right now is struggling because grants have been cut, policies have been changed. I'm sure you're all aware of what happened with food assistance during the month of November. And so want to make sure that, if you are able to, that you support the Redwood Food Bank or other nonprofits. Volunteer. This is a time where there's a lot of volunteer opportunities as we are all trying to figure out how to grapple with these changes. And if you would like to connect with us, you can get on our mailing list, and we send out information all the time. And you can also come visit one of our clinics. So you can meet some of our tremendous staff that take care of patients every single day. We're taking care of we're at like 19,000 visits a month. So it's a lot of people that we take care of throughout the city. And our staff are all very mission driven, very committed to taking care of this population. So that is what I have for you. And I'm happy to take any questions or comments from the group.
Thanks so much, Gaby.
My pleasure.
Was really informative. So we do have some questions in the chat, and if you do have questions, as I mentioned earlier, if you could please put them in the chat, that would be great. You talked about unsatisfactory immigration status. Can you define what that is for us?
So that is people that are in any kind of an immigration process, people that have maybe are either undocumented, that are refugees, that are not anyone who is not a citizen or a legal permanent resident could have problems accessing healthcare or are considered to be people with unsatisfactory immigration status. So anyone who can't come in and provide us with a social security card. Yeah.
Got it. Yeah. What impacts do you see as people start to lose their coverage, their health coverage? I mean, what's really going to happen to all of us in Sonoma County?
So people that lose their coverage will not come in for preventative care, will wait until they have to go to urgent care or to the emergency room, most likely the emergency room. People will be less productive in society, and there's a higher risk of other kinds of public health issues, right? If fewer people
Mhm.
are vaccinated, if fewer people get the flu shot, we could have a worse, flu winter, or if people are not getting the COVID shot. But I think the primary issue is that then people delay care. So they get sicker, and then the cost of healthcare goes up for everyone because now we are taking care of people in the emergency room, which is not where people should be getting their diabetes under control or anything else done. So it kind of takes all of our work in preventative care to keep people healthy and moves that to the emergency room as right, the provider, when there's a lot of when you have less options, and your health outcomes will be more negative than before. People that don't have insurance, it's also harder on our clinicians because when you don't have insurance, it puts more strain on the doctor trying to figure out, how do I get you specialty care? How do I get you in to see this doctor? Right? And so the workforce, I think, is also really heavily impacted. And I've heard a lot of doctors talk about this tremendous moral dilemma of having a patient in front of you and wanting to do everything right by them, but because of their lack of insurance, really being limited. And so you're not providing the best care that that patient needs because they can't access, they can't go to UCSF to get a specialty consult because they don't have insurance, and out of pocket, what does that mean? So you're also putting clinicians in a situation where they have to make decisions about people's healthcare based on their access to coverage, which is a horrible place to be.
Yes, indeed.
Yeah.
Can you talk a little bit about patients who are insured and do they help or hurt the care that you offer those that are uninsured? And then the second part of that question is, does the money raised by insurance from the insured add to the help you can offer the uninsured? Does that make
So can you
sense?
repeat the first question?
Sure. Do the patients who are insured help or hurt the care you can offer the uninsured?
So the way that FQs are set up is that that's the design, right? Is that if we get paid a higher rate to take care of the insured and have more insured, then there's more coming into the system to take care of the uninsured. So when you have a lot of Medicaid dollars flowing in, you can then put more services towards everyone, right? So we never have programs internally that are only for certain people. Everybody gets everything. And so the more money that I have for Medicaid, the more programs I can set up for, to educate patients, the more nurses I can hire, the more support and care everybody gets. The system is just stronger when there's more Medicaid dollars flowing in. What was the second part?
Uh, does the money raised by insurance from from those who are insured add to the help you can offer the uninsured?
Yeah, I just
Okay.
answered that.
Okay. You talked early on about you just opened your ninth location.
Hmm.
How do you assess when, and this may not be a fair question in these economic times, but in the old
Yeah.
days, how did you assess when you wanted to open a new clinic and whether it was safe for children or non-children or
Yeah, adults. So we're
adults? I
always
guess that is what a
looking,
non-child is, right? It's an adult.
we're always looking at making sure that we have enough appointments and enough access to meet the community need, right? And if there's ever a gap in access, we need to understand why that is. So the decision to open a new campus, this was actually a little different because usually it's that, do we have enough access and is it the right type of service that these patients in this location are looking for. So this one was different because this was actually an urgent care that Providence was running. It's on Corporate Center Parkway. I don't know if you all have heard about, I'm sorry, Providence closed this urgent care because they just couldn't afford to keep it running. And they came to me and said, would you like to take this over as an urgent care? But considering all of these changes, it was not financially feasible to do that. However, thinking about this other group of people that need a lot of care that we were not able to provide enough care for, and we decided, well, let's do a pediatric expansion clinic because Medicaid is safe. Like children are going to have insurance. There's no threat there. And we felt like it was also a good way to bring in new adults and new families, regardless of insurance status, to be able to educate more people and even provide primary care to more people. So, regardless of what shifts with this policy, we're going to continue taking care of everyone, including the higher uninsured rate that we, back before the Medi-Cal expansion, we had a very high uninsured rate. So we're just going to go back to that. So this was a way to expand access for a patient population that we want to care for, right? We want to get them in early, make sure they have all their vaccines or developmental screenings. And like I said, it's also a good way to bring in families into care who are not getting it already.
Good. Um, how will the uh, monetary slack be handled by the county and the state? And is there talk of raising taxes or leaning on other nonprofits or some other means for carrying those who are likely to fall through the cracks?
Yeah. So, okay, a couple of responses to that. So, all of the changes at the state level that I've talked about, like people that don't have satisfactory immigration status, not being able to enroll in Medi-Cal, those are all state changes. And so, what happened is that as soon as the Fed said, like, we have to cut Medicaid or we're going to cut Medicaid by this percentage, then the governor looked at his budget and made changes so that he could continue to afford to take care of some of these patients. So California actually is doing more than some other states to keep some of these vulnerable people insured. So that's really important. What was the second part of that? Sorry.
Um, See, is there talk of raising taxes, leaning on other nonprofits, or some other means
Yeah.
of filling the
Yeah.
gap?
So I have not heard anything about raising taxes. And one of the things that the feds are doing is putting a cap on taxes that can be raised at the state level to fund Medicaid. So that's one thing. Um, what was the rest of that? Sorry.
Uh, Go back. Uh, I think
Oh,
you answered.
nonprofits stepping in.
Yeah, nonprofits or some other means. But
Well,
for,
not necessarily nonprofits, but there will be foundations, right? So there's a lot of big foundations in California that will probably shift their focus to filling the gaps left by these changes. Or at least that is the hope. I can also tell you that locally, like a bunch of us are getting together, like local FQ CEOs and the county, and we're just in the hospitals. And so we're all talking about like how are we together going to collaborate so that we do our best to ensure that the safety net is still there. It might not look exactly like it does now with less funding, but we will do our best to make sure that uninsured people still come in. And the way that FQ works is if someone comes in and we have a sliding scale for uninsured people, right? So you are asked to pay something. If you don't pay it, we don't send you to collections. So we provide the care. If you can pay, great. If you can't, we'll send you an invoice. If you can pay that, great. And if not, then we write it off. And the federal government knows that we're going to have to write some of these off. So again, it's just weakening the safety net is what all these changes are doing.
you mentioned about a federal law regarding state taxes or
Mhm.
what states can tax related to healthcare. Can you explain that a little bit?
Yeah.
And
So states are able to raise taxes to support the gap in the Medicaid reimbursement. So let's say that the federal government gives us a million. No, yes, we work a little bit with Indian Health Center. I'm sorry, I just saw that question pop up. So for example, there's a managed care tax. That's a good example. So the feds say, okay, this is how much money California is getting in Medicaid dollars. You are getting these dollars for this number of people. And then the states have to raise some of that portion. So the feds do not fund Medicaid 100%. They give us some, and then the states have to match that. And the method that some states have been able to use to raise additional funds are through taxes. So, like, there was a managed care tax, which meant that in California, all of the managed care programs, like Partnership Health Plan and some others, had to pay a tax that then would go to help the safety net. So,
mhm.
things like that.
Okay,
Mhm.
interesting. Um, has the federal policy around DEI affected impacts of your services?
So, not our services, but the way that we talk about our services. So they have said that they are not supporting diversity, equity, and inclusion. And so we are not changing what we do, we are changing what we call it. And the federal government does not fund us specifically for any kind of DEI work. And so diversity, equity, and inclusion is kind of the mantra of community health centers. Like that's kind of what we do. We are here to see everybody. And so this has been really challenging. But again, at least me, I have decided that I'm just gonna be careful about what we call things and how we approach things. But this is what we do. We provide care to all communities, and we actually are very proud of all of the work that we do around gender affirming care, and taking care of people that are marginalized or disenfranchised. Like that is what a good community does, embraces everybody. We're going to continue doing that.
Good, thank you. Just for those in the audience, please, if you have questions for Gaby, please put them in the chat. You saw the question about Indian Health Center, so you are working with them along with the other healthcare
Yes.
providers.
Yes, not as much, but we will engage them more. Mhm.
Okay. And then there's a question around OB care.
OB
I'm
care?
assuming that means obstetrics, but I'm not sure.
Yes.
Um, and how's that going to be affected by the cuts?
That's a great question. So pregnant women will go back to having emergency Medi-Cal. What that means is that their Medi-Cal will not cover primary care for them unless they're pregnant. And so you apply when you get pregnant, and it covers you through postpartum, a few weeks after postpartum, and then you no longer have Medi-Cal. So it's just going to go back to being emergency only, which is not great, but it's better than nothing. What I think is going to be more harmful, are people or women afraid to go deliver in hospitals because they're afraid of being targeted for deportation. And right now, I think there's not a lot of ICE activity in this area, so it's pretty quiet. But when they landed in the Bay Area, we definitely saw an increase in no-shows. And some of my doctors tell me that, the conversations with patients are saying, well, I'm scared to go to the hospital to deliver my baby, or not going out in public with both parents. This is one thing that families are doing, is that when they have kids, then one adult will stay home. They're never together in case somebody is held for deportation or for ICE issues, then both parents are not together. But, these are the kinds of things that families are having to grapple with right now.
Wow. And is the CHIP program for kids' healthcare going to be affected?
Not that I know of. And so right now, most children in the United States have access to healthcare, and I do not believe that Medicaid is gonna for children is gonna be touched. It seems like it's gonna stay fully funded. So I haven't heard anything about children, and hopefully not. Yeah.
A question regarding costs. And uh, so if for instance, for every $1,000 that you get in donation, what does that equate to? I know that's probably a hard thing to answer because it
Yeah.
depends on the patient, right?
Yeah. I mean, that's a hard thing to answer because every patient has unique medical needs.
Right.
But I would say that, $1,000 can be very, very helpful. Like, for example, if you wanted to donate $1,000 to take care of someone who has diabetes, for example, who is uninsured, that might pay for some insulin or for some other things that they need. So I think that every single contribution to any FQ is helpful because we are all now starting to think about like, okay, are we gonna have to set up some funds? Or how do we make sure that patients that are uninsured don't get inferior care? How do we make sure that they continue getting high quality care? And donations will be really important to help with that. So I say whatever you want to donate to your favorite FQHC is the money will be well used and will go to patient care.
Great. And it sounds probably when you talked about the collaboration, I guess is that's a message that you all are going to start getting out to the larger community about how everyone can help in this problem.
Yes. Yes, absolutely. We're going to be doing that collectively, but I think that if you already have a relationship with a community-based organization or an FQ, reach out to them because we're all in this together. We're all trying to figure out how we're going to keep providing the services that we are providing. There was a
There's a
question about skilled nursing
yeah,
facility
yeah.
program. So this is just I can get back to you with more information on this. This is just a workforce development program. So there's a lot of money that goes into supporting, enhancing the workforce. So this means that a program that was meant to put healthcare work to train healthcare workers to work in SNFs is being cut. So that's a potential reduction in workforce investment. So that'll affect patients because there aren't as many trained professionals that are that are looking to go into that specific industry because the incentive has been removed.
And then related to that, there's a question about do you think this private skilled nursing facilities will close or raise their fees because of this?
I'm not sure about that. I don't know if they can raise their fees because Medicaid and Medicare patients, we can't like, impose arbitrary fees on them. But I can find out about this and get back to you. This is not my area of expertise. It was on one of the slides, but I'm happy to get more information and bring that back to you. Is that good, Karen?
Yes, that'd be great. And I think it's more that has to do with more
Yeah.
the private pay skilled nursing facilities. So, um,
Oh, private pay skilled nursing facilities will probably increase their costs because the price of just doing business in healthcare is going to go up. So,
right. And if they lose some of their workforce,
yeah, if they can't attract enough
yeah,
qualified people, yeah, it's all a domino effect.
yeah. Um, and then that follow up on that is about people taking who take Medicaid, folks. So it sounds like you'll get back to us with
Yes, I will
additional
get back to you
information.
on that. But this is one of the challenges is that as the Medicaid dollars decrease, some of these organizations are either going to have to reduce the amount of care that they provide, reduce
Hmm.
their hours, or shut down. I think you're going to see a combination of all of those things.
Got it. Okay. I think that was probably the last question. And I'd like to thank you so much for providing us with these hard things to hear, but important things to hear. So,
Yeah. And I'm
and thank
happy to
you for
come
all the
back.
work that you do.
Yes, and I'm happy to come back and report on our progress or give you an update once these things kind of start to fall in place. But I think the most important takeaway is it's not happening all at once. It's getting tied up in legislation. So it's a long road Stay informed, stay in touch with your elected officials. They need to hear from us all the time. And donate and volunteer to your favorite cause because we're all in this together.
Great. I love those last words of wisdom. Thank you.
Thank you so
Um,
much. Pleasure to be
thank
with all
you.
of you.
I would like to mention that our next monthly meeting is going to be January 26th at 12 o'clock with retired Press Democrat reporter Mary Fricker talking about rising income inequality. And there is more information on the website on that. So with that, thank you everyone for being here today. And thank you once again, Gaby.
My pleasure. Bye-bye.